So hi friends, I'm Dr. Anshul Bansal again joining you on this Unacademy platform. In today's YouTube live session, we'll study about Clubfoot and also we'll study about साथ में ही DDH or CDH, that is developmental dysplasia or the congenital dislocation of hip, and small one-liners वाले pediatrics से related orthopedic questions and topics. So we'll discuss all this in today's lecture. Okay, so this lecture is important for the FMG aspirants. The examination is due next month, and also for the NEET PG 2022 we'll study here everything about the clubfoot and CDH and other pediatric naam wale diseases. Okay, so let's start today's session. Currently I am working as an orthopedic house surgeon in SMS Hospital Jaipur, and I have cracked the NEET PG examination last year, that is in 2020 only. And here I am here to guide you for the subject of orthopedics, and here we'll study orthopedics in depth so that not only you can crack your competitive examinations like NEET PG, INI-CT, FMG, etc., but also you can do well in your prof or university examinations, and also you can build up your concepts. Okay, so before starting, I will just guide you about a various subscription plans that are available for the NEET PG on Unacademy. The first one, that is the subscription plan that is available on Unacademy, is your Plus subscription. The Plus subscribers will get access to all our live as well as recorded classes. They can access our entire QBank, and they can compete in live tests and quizzes, all of which is found by the topmost faculty for the NEET PG in India. And also, we'll allow the subscribers to log into multiple devices with the same account so that they can study on any device of their choice at any time. And also, for the subscribers who will be subscribing for 12 months or more, we will be shortly providing them with the printed notes. While subscribing, you can use my code, that is Anshul B10, to get extra 10% off. The second one and the best one is your iconic subscription, and it is best not only on the Unacademy but across any digital platform for NEET PG in India. And what makes this best is that apart from the things that I have mentioned you earlier, वो सब तो आपको मिलेगा ही. In extra में you will get the prep ladder and all of the prep ladder, including its entire QBank, the video lectures, rapid revision courses, grand test, etc. And on Unacademy extra में you will get well structured live batch wise classes, and we have formulated our batches and structured a course in such a way so as to build your basic concept about any subject or topic first, then going into its in depth. And also, after every test that you will give, the iconic subscribers will get an individual test assessment sheet so that they can analyze themselves ki, yes, this topic or this subject needs more revision. Yeah, what are the important topics or pointers that are asked frequently, or which type of questions are asked from this topic. So all of this is very important in planning your journey for cracking any competitive examination. And while subscribing for this subscription course, you can use my code, that is Anshul B10, to get extra 10% off. And also, in every class I always focus on the special class, and I always motivate my students to attend the special class because they'll give you extra edge over your competitors. And also, they are a very live interactive classes where you can get a classroom like feeling. You can interact and solve your doubts with the educators there and there only. You can participate in polls, you can watch the special classes anywhere anytime. What you have to do, you have to just download the mobile application of the Unacademy and log in using my code, that is Anshul B10, and both of which are absolutely free. And also, for after every special class that you will attend, you will also get the digitalized notes of that class. We have launched a QBank. A QBank is very effective because it contains every type of question that is required for you, and also that might be asked in your examinations. A QBank contains questions which will cover your entire theory part. It contains questions, the previously asked questions, recall questions of previous year's examinations, the image based questions, x-ray, CTs, MRI based questions, the pathological slide based questions, the recent advances, and very importantly the clinical based scenarios and the clinical based questions. So all of these are available on our Unacademy QBank. So please do solve a QBank. And also we have launched a new feature which is called as raise a hand feature, and we have launched this feature to make the digital platform more interactive and to increase the communication between the learners and the educators. What you have to do, you have to just tap on a button so that you can digitally raise your hand, and your educator will come to know about your doubt, and you can solve your doubts and queries there and there only. And also we are organizing a NEET PG combat on 28th of November at 5 p.m. and this is a very unique concept where you have to solve 45 questions in 60 minutes. It will be a live test, and based on your performance and the rank, you can win exciting prizes and scholarships worth 1 crore rupees. What you have to do, you have to just enroll for this NEET PG combat, which is absolutely free. You can enroll it on a mobile application as well as a website, and while enrolling you can use my code, that is Anshul B10, and remember it is absolutely free. What you have to just enroll and participate in the live NEET PG combat test on 28th of November at 5 p.m. Okay, so here are the various scholarships that you can score based on your ranks, and also the top 100 rankers will get amazing exciting Amazon vouchers and other gift coupons. Okay, so please do participate in the NEET PG combat and enroll for it as soon as possible. And also these are the various subscription plans for the plus as well as the iconic subscriptions, and here you can see that the cost per month decreases significantly if you increase the duration of your course. So economically also it is beneficial, and also it is desirable to have a single source of information from the word go of your preparation, so that you don't have to hop around and you don't have to study different topics or different subjects from different digital platforms. Okay, so please do subscribe for course with longer duration, and while subscribing you can use my code, that is Anshul B10, to get extra 10% off. Okay, so let's start today's session, and we'll start with the Clubfoot. Okay, so what is the difference between Clubfoot and CTV? See, Clubfoot is basically a vague term which defines all the congenital deformities of the foot, and in Clubfoot the most common deformity is your CTEV, that is your congenital talipes equinovarus. Okay, so don't get confused, दोनों एक ही है. There is a minute difference between all of this, between both, and the difference is that CTEV is a type of clubfoot. Okay, and one question that might be asked, not in direct term but in one of the four options of the correct one or the wrong one, is that its incidence of Clubfoot or CTV in India is 1 in every 1,000 live births. Okay, now relevant anatomy mein, first of all you have to know what is ankle joint. Ankle joint is between tibia and talus, and very important is your subtalar joint. Subtalar joint is very important in CTV, and this subtalar joint is between talus and the calcaneum, whereas calcaneum articulates with the cuboid, so calcaneo-cuboid joint, and talus articulates with the navicular distally, so it is your talo-navicular joint. Okay, now foot basically is divided into hind foot, midfoot, and forefoot. So forefoot is the most distal most part of the foot, which contains the heads of the metatarsals and the phalanges, etc. The midfoot will contain the talonavicular and the navicular cuneiform joints, whereas the hind foot, which is the most important part where most of the pathology related to the clubfoot is seen, and it comprises of two very important joints, the subtalar joint and the calcaneocuboid joints. So this is your hind foot, very important, remember this कि hind foot में कौन कौन से joints आते हैं. Okay, so this is the basic anatomy. This is your distal part, this is your proximal part, means this is your ankle joint, this is your medial part, and this is your lateral part. And here you can see this is your calcaneum, this is your cuboid, and this is your subtalar joint with the talus and the calcaneum, and talus articulates with the navicular, talonavicular joint. And here you have the three cuneiform bones, the medial, intermediate, and the lateral. Okay, so these are the tarsal bones of the foot, and you should know the basic anatomical position of these bones. Okay, this is the AP view of the foot. So here you can see this is your calcaneum, which is articulating with the cuboid, and medial to the calcaneum you have the talus, which articulates with the navicular, and the navicular articulates with the cuneiforms. And on the metatarsal of the great toe, that is the first metatarsal head, you have the two sesamoid bones. Okay, these are the two sesamoid bones. Okay, this is the lateral view. Here also you can see that this is your leg bones, tibia and fibula, this is your calcaneum, this is your talus. Okay, so talus articulates with the navicular, so this is your navicular bone, and these are your cuneiforms, the metatarsals and the phalanges. Okay, now joints we have discussed. Now we'll discuss the important ligaments. The ligaments, the important ligaments are first of all the deltoid ligament, which you all know is on the medial side of the ankle, and this deltoid ligament is called as the medial collateral ligament. Now there are two important ligaments, spring ligament and the interosseous ligament. Spring ligament is between the calcaneum and the navicular, whereas interosseous ligament is between the talus and the calcaneum. Okay, calcaneum and talus के बीच में interosseous ligament, calcaneum and navicular के बीच में there is spring ligament, and all other joints are surrounded by the individual capsular ligaments. Okay, so just remember spring ligament, deltoid ligament, and interosseous ligament. So here you can see this is your deltoid or the medial collateral ligament on the medial side, whereas this is your calcaneum, this is your calcaneum, this is your navicular, this is your talus. So calcaneum navicular के बीच में this is your calcaneonavicular ligament, which is also called as the spring ligament. Okay, this is your spring ligament. Capsular ligaments सिर्फ पता होना चाहिए कि what are the capsular ligaments, that's it. And the plantar ligaments, which maintain the longitudinal arch of the foot. Okay, this is your longitudinal arch, this one. Okay, and on the plantar aspect you will see that there is this arch, this is your transverse arch of the foot. Okay, now joints हो गए, ligaments हो गए. Now we'll come to the tendons. So tendon में most important tendon related to the pathology of the clubfoot is your tibialis posterior tendon. Okay, tibialis posterior tendon is very important muscle or the tendon, and this tendon को identify कैसे करेंगे? It is situated just behind the medial malleolus. Okay, and behind the tibialis posterior tendon you have other two tendons, that is your FDL and FHS, flexor digitorum longus and flexor hallucis longus, accompanied by the posterior tibial artery and nerve. Okay, so while dissecting you have to take care of this artery and the nerve. Okay, and posterior tibialis tendon ka main insertion is on which bone? It is on the navicular bone. Okay, remember tibialis posterior is inserted on the navicular bone. Now we'll come to the very important part for the understanding as well as from your examination point of view, is the nomenclature of the various foot deformities. Okay, so we have read ki equinovarus या calcaneovalgus. Okay, so what are these terminologies? It is very important. If you will understand this and know this, then you can solve majority of the questions. So equinus, what is equinus? Equinus means horse. Okay, so horse walks on toes. So child walking on the toes, it is your equinus deformity, and its opposite is your calcaneus deformity, means child walking on the calcaneum on the heel like this. Okay, so this is your calcaneus. Now varus and valgus we have discussed many times कि valgus में L आता है, L for lateral, यानी there will be lateral deviation. So laterally foot में क्या होगा? There will be eversion and abduction. Okay, so the foot is everted and abducted, that is your valgus deformity, and inverted and adducted will be your varus deformity. Okay, so equinus on toes, calcaneus on the calcaneum or the heel, varus adducted and inverted, valgus everted and abducted. Cavus is nothing but exaggerated longitudinal arch. See, generally it is like this, but if the longitudinal arch is exaggerated, the medial border will be more curved. This is your cavus. And if this longitudinal arch is flattened, this will be your planus. Okay, plane, flat means plane, so it will be your planus. And flattened transverse arch is called as your splay. Okay, now out of these, the most common club deformity in the club foot is your equinovarus, because individual deformities are rare, they are basically in combination with each other. So the most common combination or the most common deformity is your equinovarus, and the second most is your calcaneovalgus. This is the second most common. Okay, remember this, this is important. Now here you can see walking on the toes, so this will be your equinus deformity. Okay, here you can see the inverted and the adducted foot. Okay, inverted and the adducted foot, so this is your varus deformity. Okay, this is your varus deformity, very well appreciated in the picture. Okay, this is your varus deformity. Okay, so this is your normal foot, and in club foot here you can see that there is exaggerated longitudinal arch with varus deformity. Okay, it is inverted and adducted, so varus deformity. Okay, cavus is exaggerated longitudinal arch, so when longitudinal arch will be exaggerated, there will be more bending of the medial border, leading to the deep crease on the medial side. This is your cavus deformity. This is your adduction deformity and varus deformity. Okay, now this is your flattened transverse arch, flattened transverse arch, which is called as the splay. Okay, this is your flattened transverse arch, which is called as the splay. Okay, so talipus is the generalized word. इसके बाद जो भी deformity होती है उसका name आ जाता है, like talipus equinus. But basically we have already seen that there is the deformity is in combination. So talipus equinovalgus, so equino on the toes, valgus means abducted and everted. Okay, calcaneus on the heel, exaggerated longitudinal arch you can see like this. Okay, arch is more exaggerated, more curved, so this is your cavus deformity. Okay, equinovalgus, this is your calcaneovalgus. Okay, very easy. If you know the basic terminologies, then the identification will be very easy. Okay, now etiology of the clubfoot or CTB. So most commonly it is idiopathic. Okay, most commonly it is idiopathic, which is called as the primary clubfoot. But in certain conditions there are associated other congenital diseases or other muscular diseases, due to which CTEV or the clubfoot arises, which is called as the secondary CTEV. Okay, and इसमें से most important is your AMC, that is your Arthrogryposis multiplex complex. Okay, and what is this Arthrogryposis multiplex congenita? Is a muscular disease which affects almost all the muscles of the body, and there is weakness in the and atrophy in of the foot muscles, which will lead to the club foot. Okay, now idiopathic means no short cause is known. So there are various theories like mechanical theory related to the intrauterine pressure during the intrauterine life, or the ischemic theory due to the ischemia of the calf muscles during intrauterine life, and obviously the genetic theory due to some genetic disturbances. So itna deep में you don't need to go. For the prof and university examination students, you just need to identify, you just need to remember कि there are three theories which support the idiopathic cause of the clubfoot. Now, secondary clubfoot we have discussed. Most important is your arthrogryposis multiplex congenita. Okay, and other diseases are the paralytic disorders which lead to the weakness of the muscles and atrophy of the muscles, which lead to the CTV. And इसमें most important जो आपको याद रखना है, that is polio and spina bifida. Okay, polio and spina bifida, and especially spina bifida patients, patients are very frequently associated with the clubfoot. So polio, spina bifida are very important. इसके अलावा myelodysplasia, Friedreich ataxia, ये सारा these are also associated. Okay, and in paralytic disorders or the secondary clubfoot also, the most common will be a equinovarus deformity. Okay, equinovarus deformity. Now, if we come to the pathoanatomy, the bones में we have already discussed कि subtalar joint between talus and the calcaneum is the most important, and talus की normal anatomical position you should know that it is downwards and medially. Okay, so the head of the talus is facing downwards and medially, and the calcaneum is small and it is medially concave. So subtalar joint is important because here which type of deformity occurs? Here the inversion deformity occurs, or you can say the varus deformity. Okay, so inversion deformity occurs at the subtalar joint. It is very important. Okay, forefoot adduction at the navicular joint, and the forefoot cavus, that is exaggerated longitudinal arches at the mid tarsal joints. ये important नहीं, important is your subtalar joint, and इस पे कौन सी deformity होती है? इस पे there is your adduction, inversion deformity. Now muscles and tendons we have already discussed. एक तो tendoachilles tendon होगा, and this is related to the equinus deformity. Okay, and then you have the three tendons of the tibialis posterior, FDL and the FHL, and the capsules and the ligaments, the deltoid, spring, talonavicular ligament, interosseous ligament, etc., and the plantar aponeurosis or the plantar fascia. Okay, so we have already discussed all of this. Now skin condition is very important, and it will help you to diagnose clinically CTEV. Okay, so skin condition में you have to check for two things. First of all, on the medial border में due to the cavus you will have the deep crease. Okay, on the medial side of the sole you will have the deep crease on the medial side of the sole, whereas on the lateral side में you will have the dimples. Okay, with prominent bony prominences. Okay, so there will be bony prominences on the lateral side with dimples, dimples होंगे, bony prominences होंगे, and there will be callosities and bursas. Okay, there will be callosities and bursas over the bony prominences on the lateral side. Okay, so ये चीज you need to remember. In the image also you can see that this is your medial side. This is your medial side. So on the medial side you can see, due to the cavus deformity, you have a thick palmar crease, okay, or deep palmar creases, whereas on the lateral side, I'll show you the picture of the lateral side also. Okay, here on the lateral side, this is your lateral side. Here you will have the bony prominences with dimples and callosities and bursas. Okay, and callosities and bursas. And as you can see here, the heel will be small and high with more fatty heel. Okay, with more fat. Okay, so heel will be small and high and more fatty heel, and the calf muscles will also be thin, abnormally thin. So remember कि CTEV or clubfoot is not just the deformity of the foot alone. Okay, CTEV or clubfoot is not the deformity of foot alone, it is deformity of the entire leg. Okay, now clinical features may the deformity is the main clinical features, and the deformity is very easy to diagnose clinically. Okay, so due to the increased prevalences of the deliveries by the healthcare workers and the medical officers, the diagnosis is becoming easier and earlier. That's why the prognosis of the CTV and the treatment of the CTV is better. So if it is detected at birth only, then the prognosis is best and very very good, and you don't have to even do the POP casting. Only manipulation, that too by the mother alone, will do the cause, and at that stage the deformity is only postural. That's why it is called as the postural equinovarus. So how will you screen the newborns? Okay, screening of the newborn is very important. So screening of the newborn is very easy. What you have to do, normally the newborn babies में क्या होगा, in normal newborn child, you can dorsiflex the foot, and you can dorsiflex the foot so that the tip of the toes can touch the anterior part of the shin also. Okay, so in this way you can do the screening. And also, if the child is brought during early infancy, that between 3 to 6 weeks of the age, then also you can very easily treat CTV, and the prognosis is still good. But due to negligence, especially in the rural population, unavailability of the better healthcare programs, and also due to malpractice of the quacks, etc., sometimes child comes during late infancy, or after 1 years 2 years of the age, or even after 5 years of the age. So these are called as the neglected CTV, and in these cases the prognosis is not so good. Okay, you need corrective surgeries, etc. So it is a major problem in developing countries. Still in India, in our OPD, we get many patients after 2 to 3 years of the age with rigid CTV and the rigid clubfoot. So they are very hard to manage, and the prognosis of such patients is not so good. ओके, तो स्किन चेंजेस वी हैव ऑलरेडी सीन. डीप क्रीज होगी मीडियल साइड में. लेटरल एस्पेक्ट में यू विल हैव द डिंपल्स, callosities, bursas, bony prominences, and on the medial side deep crease hogi due to the shortening of the medial side of the sole. And also, as I have told you, it is the disease of the entire leg, so there will be atrophy and the hypoplasia of the peripheral vascular vessels like the dorsalis pedis and the anterior tibial artery, etc. Okay, now examination of the foot, we have already discussed कि newborn child can be dorsiflexed until the dorsum touches the anterior aspect of the shin of the tibia, and in majority of the cases, more than 60% of the cases, it is bilateral, and the size of the affected foot is smaller. Remember, affected foot ka size is smaller as compared to the normal foot. Okay. Now, foot in CTV, it is in equinus, varus, and adduction. Okay, with cavus deformity. Okay, so heel size is small and heel is raised, more fatty, as you can as we have discussed. Deep skin creases on the medial side, bony prominences on the lateral side, and the outer side, which is the lateral side, will be more convex. Okay, with dimples on this side, with dimples on this side. Okay, and also another screening test apart from the dorsiflexion is that in case of any deformity, if you try to correct the deformity and you feel the structures posteriorly, that is your tendoachilles or at the plantar side, the plantar fascia, you will feel that these structures are very tight. Okay, so these structures are very tight, and these are the screening tests that can be used by the healthcare workers at the primary level to detect and diagnose CTV at an earlier stage, so that the treatment can start very early. Okay, तो जनरल एग्जामिनेशन वी हैव ऑल सीन कि कोई भी सीटीवी का क्लब फुट का केस आ जाए, यू हैव टू रूल आउट द secondary causes, that is the AMC and the other paralytic disorders like spina bifida, Friedreich's ataxia, polio, etc. Okay, now there are certain other terminologies which are associated with the CTV. सबसे पहले what is supple? Supple especially in the early diagnosed cases, or in the newborn child, or in the early infancies, you can correct the foot deformity or the club foot deformity by manipulation alone. So this is called as supple, that is foot can be brought to the normal position. Rigid CTEV is where the foot abnormal deformities are not corrected. Okay, this is your rigid deformity, and it occurs in the generally in the neglected cases, or the cases which are presented after 1 to 2 years of the age. Resistant CTEV is the refers to the patients who have undergone the entire protocol of the manipulation, POP, casting, etc., but still the deformity is not corrected. It is called as the resistant. Whereas neglected ones are those who have already diagnosed कि yes, this child has CTV, but still the child has not undergone any treatment for 1 year. That is called as the neglected uh, CTV. And relapsed is that the CTV which got corrected, okay, by the treatment, manipulation, casting, etc., but it has recurred. Okay, and the most common cause of relapse is that you have not undergone the maintenance of the CTEV. Okay, so maintenance is very important. Of maintenance of the correction is very important, and maintenance of the correction, we will see it is done by CTEV shoes or Dennis Brown splints, etc. Okay, splints, shoes, they are used for the maintenance of the deformity. Okay, now, differentiating between the primary and secondary clubfoot, we have already discussed the primary one is the idiopathic and it is the congenital one. Okay, and most commonly bilateral. Foot size will be smaller and fat will be more, means it will be chubby. Okay, primary congenital hoga, bilateral hoga mostly. The foot will be smaller, more chubby, more fatty. Okay, and very importantly, the neurological examination will be normal, and very important, primary club foot ka prognosis is better as compared to the secondary club foot. Okay, primary clubfoot का prognosis is always better as compared to the secondary clubfoot. Okay, now talocalcaneal angle are important, but उसमें आपको सिर्फ इतना सा याद रखना है कि normally the talocalcaneal angle is more than 35 degrees in the newborn. Okay, but in CTEV this angle is decreased. You have to just remember कि CTEV में the talocalcaneal angle is decreased, and इसमें the most important is your Kite's angle. Okay, so Kite's angle क्या होता है? If you draw a line, two lines, one through the long axis of the calcaneum and second to the long axis of the talus, and ये दोनों lines जो angle बनाती है, that is called as your talocalcaneal angle or the Kite's angle, and it is less than 35 degrees in case of CTEV. In case of CTEV. Okay, now treatment basically depends on the age of presentation. Okay, treatment depends on the age of presentation, and most of the cases nowadays are presented in the early infancies, within 1 to 3 months of their age. Okay, so the prognosis is very good, and in those cases less than 1 year, maybe the treatment of choice is your manipulation and serial POP casting. Okay, so we'll see about we'll see the treatment protocol in terms of the age of the presentation only. Okay, so if it is detected at birth or very early in the infancy, so at that time only manipulation is required, which is called as the postural CTEV, and it can, there is no need of any doctor, no need of any POP casting, only the mother can be taught how to do the manipulation. Okay, so mother is taught कि yes ऐसे manipulation करते हैं, ऐसे normal anatomical position of the foot में hold करके रखना है, and you have to put the pressure on the foot in such a way so that the fingers of the mother is blanched. First thing. Second thing is timing. Every time the mother feeds the child, she has to follow the entire steps. Okay, so how, and the timing is that 5 seconds के लिए you have to hold it, है ना, then give a rest for 5 seconds, then again for 5 seconds hold it, and you have to do it for minimum 5 minutes during every feeding session. Okay, so normal anatomical position, you teach the mother how to hold it, and what is the perfect pressure, what is the perfect timing, and for which time period or time duration you have to do it, and it is very easy and the results are very very good. But if the child is presented after 3 to 6 weeks of the age, okay, then you have to go for the manipulation plus POP casting. Only manipulation will not do the work. Okay, now इसके लिए you have two types of technique of manipulation and POP casting. First is your Kite's philosophy, and second is your Ponseti philosophy. So in general we follow in hospital settings, and the better one is your Ponseti philosophy. Okay, sorry, remember the better one is the Ponseti philosophy, and it is followed. So अगर कोई philosophy का नाम नहीं दे रखा हो and you have asked any question related to the treatment, then you have to answer it according to the Ponseti technique or the Ponseti philosophy only. So we'll first read about the Ponseti philosophy, then we'll discuss the difference between the Ponseti and the Kite's philosophy. Okay, so Ponseti philosophy में जो एक important चीज you have to remember is your calcaneocuboid navicular complex, and the the position of the talus is, according to Ponseti, is plantar flex talus, and the complex जिस पे all the focus is there on of the Ponseti philosophy is the calcaneocuboid navicular complex. Okay, so here you put the pressure by the thumb over the head of the talus. Okay, whereas in the kite philosophy the pressure is over the calcaneocuboid joint. In Ponseti the pressure is over the head of the talus. First difference. Second difference is that in Ponseti technique cavus deformity is corrected first, which is followed by the adduction, and varus deformity and equinus is corrected at the last. And equinus deformity is corrected at the last, whereas in kites philosophy you first correct the adduction and the varus deformity, whereas in Ponseti you first correct the cavus deformity. And remember, it is a very frequently asked question that all the deformities are not corrected simultaneously. Okay, so पहले cavus करेंगे, then adduction varus deformity, and at the last you treat the equinus deformity. And for equinus deformity you have to do a minor surgery which is called as the tenotomy. So tenotomy is release of the tendon, okay, or cutting of the tendon. And which tendon? The tendon is that of the tendoachilles. Okay, tendon is that of the tendoachilles. You can do it as a local procedure only. You can sorry, do it as the local procedure only. Okay, now एक और differentiation feature is that in Ponseti philosophy you put the above knee cast, whereas in kite you put the below knee cast. Sorry. In Ponseti you put the above knee cast, whereas in the kites philosophy you put the below knee cast. And also in Ponseti technique the treatment is started within first week of life only, and every 7 days you have to go for the serial casting and manipulation, whereas in the kites every 2 days, sorry, every 2 weeks you do it, and it is started after at least 3 to 4 weeks of the life. Okay, so kites philosophy at the age of 1 month, yani 3 to 4 weeks of the life हो गया. And इसमें as we have discussed adduction and inversion corrected first, then the equinus every 2 weeks, वहाँ पे every 1 week था. And here it you overcorrect the deformity, then you go for the maintenance device. Below knee cast are applied, okay, and it takes at least 6 to 9 months, and the correction is achieved only in 30% cases, whereas in Ponseti it takes only 3 to 4 months to get corrected, and the result is positive and good, and more than 70% of the deformities are corrected. Okay, so these are the difference between the kites philosophy and the Ponseti philosophy. Okay, so kites error, जो common error होता है, what are those? The common errors are pronation or eversion of the first metatarsals, there is premature dorsiflexion of the heel, and there is counter pressure on the calcaneocuboid joint, whereas it has to be on the head of the talus. Okay, so 5 to 7 days. Tenotomy we have already discussed. Okay, Ponseti technique we have discussed this technique. Okay, here you can see this is your above knee cast, and remember the above knee cast is put with knee flexed. Why? Because knee extended होगा तो टेंडो एक्लीस पे और ज़्यादा pressure होगा, तो there will be more tightness and rigidity of the tendo achilles. Okay, that's why the knee is flexed in the above knee cast. Okay, now this is the treatment protocol of the child who have presented at a decent age, but child who have presented after 1 year of the age, or child who is resistant to all of the treatment, then they have to go for the surgeries. Okay, they have to go for the surgeries. So if less than 3 years of the age, then you go for a surgery, which is very important. You need to remember this surgery. This is your PMSTR, that is your posterior medial soft tissue release, यानी पोस्टीरियर एंड मीडियल एस्पेक्ट ऑफ द एंकल एंड द फुट पे जो भी रेलिवेंट सॉफ्ट टिश्यूज होंगे रेलिवेंट टू द क्लब फुट, यू विल रिलीज देम. दिस इज कॉल्ड योर PMSTR, दैट इज पोस्टीरियर मीडियल सॉफ्ट टिश्यू रिलीज. तो इसमें कौन कौन से स्ट्रक्चर्स आर रिलीज्ड और कट? सबसे पहले टेंडो एक्लीज की लेंथनिंग होती है बाय द जेड प्लास्टी, देन द टिबियालिस पोस्टीरियर, flexor digitorum longus and flexor hallucis longus. These three tendons are released. Okay, then subtalar joint is released with plantar fascia. Okay, so three tendons: tibialis posterior, FDL, FHL. Three ligaments: the talonavicular ligament, the deltoid ligament, and the spring ligament between calcaneum and navicular. Okay, and capsules of the joints, and also plantar fascia. Okay, and also the plantar fascia is released. Okay, also the plantar fascia is released. Okay, so this is very important in the PMSTR. Okay, now if there is single deformity, like if there is only equinus or if there is only cavus, then you have to go for the limited soft tissue release. सारे posterior medial soft tissues को release करने की जरूरत नहीं है. So you can go for the limited soft tissue release and also the tendon transfers. बस नाम याद होना चाहिए कि tendon transfer भी कर सकते हैं, and you use the tendons of the tibialis anterior and posterior. Now only remember the name at least, that is Dewar's osteotomy is used in case of CTEV. Dewar's osteotomy is used in case of CTEV at 3 to 4 years of the age, and this osteotomy is of the calcaneum bone. This osteotomy is of the calcaneum bone. Okay, so bus itna sa you need to remember. And also Dillwyn Evans procedure is also used for the CTEV. Okay, Dillwyn Evans procedure is also used for CTEV. It is PMSTR with calcaneocuboid fusion. Okay, so Dillwyn Evans osteotomy and Dewar's osteotomy in the CTV. इसके अलावा you have two other surgeries, that is your wedge tarsectomy and your triple arthrodesis. तो wedge tarsectomy is done between 8 to 11 years of the age. अगर presentation इस age में है या फिर अभी तक you have tried all the treatment protocols and still the deformity is not corrected, so between 8 to 11 years of the age you go for the wedge tarsectomy, and after 11 years of the age you go for the triple arthrodesis, where you fuse three joints. There is fusion of three joints, that's why it is called as triple arthrodesis. And what are the three joints? First is your talus and calcaneum के बीच में joint, that is your subtalar joint, calcaneocuboid joint, and the talonavicular joint. Okay, these three joints are fused. This is called as the triple arthrodesis. Okay, so after, and also you can go for the Elizaro technique in case of resistant or neglected CTV which are presented very late, and a special type of JES which is called as the CTEV JES can also be used. Okay, CTEV JES can also be used. Okay, now maintenance. Correction तो अपन ने सीख लिया कि कैसे correction कर सकते हैं. Now after the it is corrected, it is very important to maintain it in the corrected stage. Okay, and to maintain it in the corrected stage you have CTEV splints, डेनिस ब्राउन स्प्लिंट एंड द सीटीवी शूज। ओके, सो ये दोनों कॉम्बिनेशन में यूज होते हैं। सीटीवी शूज ड्यूरिंग द मॉर्निंग और द डे, sorry, daytime, and it is used when the child starts walking, like after 1 year of the age. And Dennis Brown splint is used during the night before child starts walking. So अगर child has started walking, then CTV shoes during the day and Dennis Brown splint during the night. And child have not started walking, then you use the Dennis Brown splint for the entire 24 hours day plus night. Now CTV shoes की characteristics you need to remember, they are frequently asked. सबसे पहले important चीज़ है इसकी, till which age you need to maintain this correction or you need to wear the CTV shoes. It is till 5 years of the age. कब तक? It is till 5 years of the age तक you need to maintain this. Okay, and now what are the characteristic feature? यहाँ पे you have the inner border, that is the medial border will be straight, not curved, so that adduction नहीं हो पाए. And the outer border will be raised, यानी it will be more thick, more elevated to prevent the inversion. And the shoe will be flat, there will be no heel. Okay, there will be no heel, so the shoe will be flat, and this is to prevent the equinus. So inner or medial border will be straight, outer border will be raised or elevated, and the heel will be flat, there will be no heel in the CTEV shoes. Okay, so it is important. Now plan of treatment we have already discussed, according to the age. And then if it is resistant etc, you have to uh, keep in mind the secondary causes like the arthrogryposis, multiplex congenita, and the spina bifida, polio etc. Okay, so resistant club feet, recurrent club feet, neglected club feet, we have discussed it all कि क्या होता है. Okay, so this was all about the club foot. I hope you have understood it very well. Now we'll jaldi se discuss about the DDH, that is developmental dysplasia of the hip, which is also called as CDH, that is congenital dislocation of the hip, or CHD, that is congenital hip dislocation. तो नाम से ही पता चल रहा है that it is congenitally spontaneous dislocation of the hip in the child, and most commonly it is during the birth only. Okay, during the birth only, at the time of birth. And if it is at the time of birth, it is called as the classical CDH, which we will study, which is the most common type. Okay, now it is mostly seen in Western countries, and its incidence is less in Indian society. Why? Because the most stable position, or the position where there is minimum chances of hip dislocation, is when the hip is abducted. So in Indian culture you have this tendency of keeping the child in godi. Okay, you must have all heard and seen that the child, there is a culture of keeping the child in godi, where the child is on the lateral side of your or on the flank with the both the hips abducted. Okay, so because of this posture, there are less chances of congenital dislocation of hip in the Indian society. So developmental dysplasia of the hip or dysplastic hip, these all are the same things which refer to the CDH. Okay, remember this thing. Now etiology, mostly it is idiopathic. It is most common in the firstborn child, that too in the female child, in the breech position. Okay, and it is more common in the females due to a hormone which is called as maternal relaxin. क्योंकि अगर male child होगा तो maternal relaxin will be there, but there will be no receptors to act. But in female child, this maternal relaxin will act on the receptors in the female child in intrauterine life, and it will relax the muscles which will lead to the CDH. Okay, so रिलैक्सिन हार्मोन की वजह से फीमेल्स के अंदर ब्रीच पोजीशन फर्स्ट चाइल्ड के अंदर मोर कॉमन होता है. ओके, सो क्लासिकल CDH dislocated at the time of birth, which we have already seen. Okay, now it is very important, which is the classical pathological features of the CDH. Okay, these are the classical pathological features of the So the classical pathological features of the CDH around the hip joint is that सबसे पहले there will be dislocation of the femoral head, and this femoral head is dislocated posteriorly, that is upwards and laterally. Okay, with small epiphysis, and its fusion is late. So that's why X-ray के अंदर CDH can only be diagnosed after 1 year of the age, because the epiphyseal fusion normally of the femur head takes place after 1 year of the age. So 1 year से पहले X-ray में you cannot diagnose the CDH very appropriately, and the femoral neck is excessively anteverted. Very importantly, the acetabulum is shallow with a deep sloping roof, hypertrophied ligamentum teres. Okay, now normally क्या होता है, there is a fibrocartilaginous labrum around the acetabulum, like in the glenoid cavity में भी glenoid labrum होता है, to make that cavity to make this cavity glenoid or the acetabulum cavity more deep, so that the head can articulate very easily. Okay, so it is called as the limbus. But in case of CDS, this there may be folding of this limbus into the cavity, which is called as the inverted limbus. So remember, this inverted limbus is the characteristic feature of the CDH, with fibrofatty tissue in the acetabulum. Okay, capsule will be stretched, and the muscles around the hip joint, they will be they will be atrophied, and there will be shortening of these muscles. Okay, so shallow acetabulum, stretched capsule, head of the femur dislocated upwards and laterally, short and anteverted neck, hypertrophied ligamentum teres, fibrofatty tissue within the acetabulum, and inverted limbus. All these are characteristic features of the CDH. Very important, remember this thing. Okay, clinical features we have already discussed. Left side में more common होता है, females में, first born child में. Okay, now diagnosis is somewhat difficult of CDH. Why? Because hip dislocation है, so the deformity or the limping will be seen only when the child is walking. Okay, so but at the time of birth, or in the early infancy, it becomes difficult to diagnose, because there is minimum movement of the child. But still, regular checkup of the healthcare worker, or the any deformity at the hip region, you can diagnose it clinically very easily, but you have to be vigilant about it, first of all. And secondly, very important is that hip is dislocated, but it is painless. Okay, it is a characteristic feature of the CDS that it is painless. It is a characteristic feature that it is painless. Okay, now examination के अंदर you do many tests. All the tests are very important in case of CDS. So most important two tests are the Barlow's and the Ortolani test. Okay, so remember Barlow में there is B for bad. That's why it is a bad test, whereas Ortolani is a good test. So why Barlow is a bad test? Barlow is a bad test because it is a two-step test, where firstly you dislocate the hip joint, and in the second step you relocate the hip joint. So you are dislocating the hip joint intentionally, so that's why it is the bad test. Whereas Ortolani test is a good test, because here you are only following the second part of the Barlow's test, that is you are only relocating the hip joint. Okay, so कैसे करते हैं? The position is self-explanatory, with the knees and the hip in the flex position at 90 degree to each other, and grabbing the thigh like this with thumb at the anterior part. Okay, and in the first part you will dislocate, so dislocation is posteriorly, so you will push inside to dislocate the femur head, and in the second step or the Ortolani test you will relocate it, yani you will pull it. Okay, so बस इतना सा याद रखना है. It is Barlow's test is bad test, Barlow's and Ortolani test. Okay, now third test is your Gallagher's test or Gallagher's sign. What you have to do in the same position like this. Okay, normally both the knees का जो superior part hoga, they are in the single line at the same level. But if Gallagher's sign is positive, yeah, they will not be in the same line. So this is your Gallagher's sign. Here you can see Barlow's test, dislocation कर रहे हैं posteriorly and relocated कर रहे हैं by pulling anteriorly. Okay, now Trendelenburg sign we have already discussed many a times कि Trendelenburg sign होगा to compensate any pathology in the pelvis. The body, what the body does, the body tries to compensate it by the Trendelenburg gait or the waddling gait and the Trendelenburg sign, where the pelvis is tilted towards the normal side or the healthy side, and the entire trunk or the body is tilted towards the disease side. So this is called as your Trendelenburg test. Okay, so Trendelenburg test, fourth test. Now fifth is your hip telescoping test. Again, hip telescoping test, if it is positive, it means ki the hip femoral head is dislocated. And how you do, like in the image, similar position mein you push the pressure, you push the femur head downward. So if it is already dislocated, you can very easily feel that the you can very easily move the femur head. Okay, so this is your hip telescoping test. Okay, this is your hip telescoping test. Now in CDH, remember, कहीं पे भी वॉन रोजिन आ जाए, वॉन रोजिन व्यू, वॉन रोजिन सर्जरी, वॉन रोजिन स्प्लिन, so you can easily say कि it is related to the CDH or the DDH. Okay, remember this thing, this is also very very important. Okay, so this is your von Rosen's view. दिखता है एक्सरे के अंदर after 1 year of the age only. And what are the things that are seen? There is delayed appearance of the ossification centers, retarded development, sloping acetabulum, upward and lateral displacement, and there is break in the Shenton's line. All these are seen as radiological features in CDH. Okay, now this is your Shenton's line, this green line, this is your Shenton's line normally, and it is broken in case of CDH and fracture neck of femur or dislocation of the hip, traumatic dislocation of the hip. In all these cases it is broken. This is your Shenton's line. Now treatment is again dependent on the age of presentation. Okay, so in general, as a rule of law, if the age of presentation is जितना earlier होगा उतना ही prognosis easy होगा. Age earlier, prognosis better. Okay, the earlier the age, the better is the prognosis. And what is the treatment of choice? If the child is less than 2 years of the age and preferably less than 6 months, 6 months या फिर examination point of view से 2 months तक, you can try only closed reduction, then maintenance. and how will you maintain it? We'll see it afterwards. But after 2 years of the age, only close reduction is um, not beneficial. Okay, the reduction is not stable, or the reduction is not acceptable. So after 2 years of the age, first you try close reduction only, but in most of the cases it will not do your work. So if close reduction is not successful, then you have to go for the ORIF, that is open reduction internal fixation using K wires, Moore spin, etc. Then you have to go for the maintenance. Okay, so as a rule of law, remember 2 years याद रख लो. And also एक और चीज याद रखनी, in case of unilateral cases 10 years के बाद you will not try the close reduction, and in case of bilateral cases after 8 years you will not try the close reduction, आप try भी नहीं करोगे. Okay, and ओपन रिडक्शन फेलियर एंड इन्वर्टेड लिम्बस अगर है, ये सारी चीज़ें, इट इज़ वेरी इजी. आई हैव ऑलरेडी टोल्ड यू. नाउ मेंटेनेंस ऑफ द रिडक्शन. मेंटेनेंस यू कैन डू in the form of cast or the splint. Splint में there will be Von Rosen splint, and in cast there will be frog or bachelors and the Lawrence cast. Okay, the images are here. Okay, so this is your frog or the Lawrence cast, and this is your bachelor's cast. Frog and Lawrence cast and bachelor's cast, and you start from this. You start from the frog or the Lawrence cast, and it is 60 40 20 degrees. Okay, 60 degrees flexion, 40 degrees abduction, and 20 degrees of internal rotation. And every 6 weeks or 1.5 months you change the spica and you do the serial x-rays. Okay, and after 6 weeks, if it is satisfactory, you go for the splint, and it is your Von Rosen splint. So just remember the image is very important for the identification. Ki what is this? This is your Von Rosen splint. Okay, this is your Von Rosen splint. Identification is very important, just remember this. Okay, now surgeries. CTEV में you have the Dewars osteotomy and the Dillon Evans osteotomy. In TDH, you have the Salter's osteotomy. You have the Salter's osteotomy, and remember Salter-Harris classification भी है. Salter-Harris classification is classification of the epiphyseal injuries. Okay, epiphyseal injuries का जो classification होता है, that is your Salter-Harris classification, and Salter osteotomy is done in case of CDH. इसके अलावा just remember the name Chiari's osteotomy, Pemberton's osteotomy, or the varus derotation osteotomy. Just remember the name. Treatment plan we have already discussed. Birth to 6 months, only close reduction and maintenance. And after that you try the close reduction, but in majority of the cases you have to go for the ORIF. So 2 years आप याद रख लो. Close reduction is generally acceptable and bears good result. Only close reduction up to 2 years of the age. And most common surgery that is performed is your Salter's osteotomy. Okay, most common surgery that is performed, it is your Salter's osteotomy. Now after 6 to 10 years of the age, इस एज में आ जाते हैं, then close reduction you cannot try and it will not give you results, so you have to go for the surgery. So here generally with bilateral dislocations you don't do surgery etc, because अगर bilateral है तो lymph जो बने होगा, lymph will be less noticeable, and the patient will live normally up to 40 to 50 years of the age. And 11 years के बाद तो you do treatment only and only if there is pain. Pain is the only indication of the treatment. Okay, because the results are not good, epiphyseal fusion and etc all have already occurred. the dislocation has become permanent, and all the structures there have become atrophied, and the dislocation is almost permanent, so the results are not very good. So only and only indication is your pain, and if there is severe pain after 11 years of the age, you have to go for the arthrodesis. You have to go for the arthrodesis. Okay. Now, in the last part of the lecture, okay, we'll discuss very quickly pediatric malformations, which are name wise very important. So सबसे पहले Klippel-Field syndrome, it is related to the cervical vertebra, where there is malformation of the cervical vertebra leading to the fusion, congenital short and stiff neck. Congenital short and stiff neck fusion of the cervical vertebra like this. Okay, there is fusion of the cervical vertebra like this. Springle shoulder is the elevated shoulder where there is congenital high scapula, यानी scapula का descend नहीं हो पाया है. So there is congenital high scapula like this. This is called as your springle shoulder. Hemivertebra and block vertebra we have studied in scoliosis. That too the congenital scoliosis. The most common type of scoliosis is the idiopathic scoliosis, but in congenital scoliosis you have hemivertebrae and the block vertebrae. So hemivertebrae, only one half of the vertebra will develop, and in the block vertebrae there will be defective fusion, so intervertebral space will not be there. Okay, so here you can see in the scoliosis you have this hemivertebrae here. Okay, hemivertebrae and the block vertebrae. This is your block vertebrae. Okay, now spondylosis के लिए you just need to remember one cheese, that there is break in pars interarticularis, most commonly in the lumbar vertebra, that to the L5 one. Okay, lumbar vertebra L5 pars interarticularis. Okay, that is spondylosis. Spondylolisthesis very easy, we have discussed it many times, that normally the vertebra are like this in the lateral view, but if there is dislocation like this or like this is called as the spondylolisthesis, that is displacement of one vertebra over the other. Okay, and this is most commonly in the L5S1. Okay, here you can see spondylolisthesis, it should be in the same line like this. Okay, like this, they should be in the same line, but here there is dislocation, so this is spondylolisthesis. Now what is diastometomyelia? Diastometomyelia is a longitudinal fibrous or bony septum which divide the spinal canal, generally seen in case of patients with spina bifida. Okay, so this is your diastometomyelia. Okay, this is your diastometomyelia. Now phocomelia, that is C limb, the proximal and the distal part जो होता है, it is present and there is lack of development of the proximal part. Phocomelia generally seen due to thalidomide ingestion during pregnancy. Okay, during pregnancy, if the mother uses thalidomide, there are high chances of diastometomyelia. Now very important is your disease where there is congenital absence of the radius bone, which is called as manus valgus or the radial club hand. Okay, this is your manus valgus or the radial club hand, where there is absence of radius bone, so the hand will be deviated in valgus, yani laterally. Manus valgus है, so hand will be deviated laterally. Okay, here you can see the hand will be deviated laterally. This is your manus valgus deformity. Congenital radioulnar synostosis में क्या होगा? Congenitally radius and ulna of the forearm bone will be fused with each other. This is congenital radio-ulnar synostosis, and in this there will be difficulty in rotation of the forearm. Okay, there will be difficulty in rotation of the forearm bones. There will be difficulty in the rotation of the forearm bones. Okay, so remember this. Now, maid lungs deformity is very important. Maid lungs deformity के अंदर क्या होगा? There is defective growth in the distal end of the radius. Okay, distal end of the radius के epiphysis में there will be deformity. So उसकी वजह से there will be dislocation of the distal radio-ulnar joint, that too the dislocation of the head of the ulna like this. Okay, this is your maid lungs deformity. Congenital deformity of the epiphysis of the distal end of the radius leading to the displacement or dislocation of the head of the ulna. This is your maid lungs deformity. Okay, syndactyly नाम से पता चल रहा है, it is fused fingers. Okay, simple if bones are not fused, complex if bones are fused, and complicated if there is some extra bone, tendon or ligament, then it is called as your complicated one. Then it is called as your complicated one. Congenital dislocation we have already discussed. Congenital short femur में there will be shortening. Clubfoot CTV we have already discussed. Now congenital coxa vara. Now neck shaft angle जो होता है femur का, it is important. It is generally 120 to 140 degrees in case of children, not in case of adult. In case of adult it is between 90 to 95 degrees, whereas in children it is 120 to 140 degrees. So अगर 120 degrees से कम है, it is called your coxa vara, and 140 से ज़्यादा है, it is called your coxa valga. Okay, now we'll come to the congenital pseudoarthrosis of the tibia. Okay, it is in the lower or the distal one third of the tibia. Okay, where there is malunion of the fracture which will lead to the pseudoarthrosis, yani false joints between the tibia and the fibula like this. So this is your congenital pseudoarthrosis of the tibia. Distal one third of the tibia में होता है. You need to identify the image and the x-ray, that will do your work. Now last is your rocker bottom field. तो rocker bottom field में क्या होगा? This is your rocker bottom field where you will have a congenital vertical talus. Here you can see this is your calcaneum, this is your talus. So talus is vertical congenitally, which will lead to the congenital rocker bottom feet like this. Okay, this is your rocker bottom feet. Okay, so this was all about today's lecture. I hope you liked the lecture. If you have any doubt, you can ask me in the live chat box right now. Okay, we have discussed the clubfoot, the CDS, DDH or the dysplastic hip, and name wale very important high yielding diseases related to the orthopedics. Okay, so thanks for watching. If you like the video, please like, share and subscribe, and watch my other videos on the special classes as well as the YouTube classes. And you can use my code, that is Anshul B10, while subscribing for any of the Unacademy subscriptions to get extra 10% off. Okay, so thanks for watching. Thanks for watching. Bye bye. Thank you. Bye.